More than 150 healthcare organizations were accepted for the first access cohort, which officially launched this week. This list includes traditional medical groups, but also nutrition companies, behavioral health providers, care navigation platforms, remote monitoring companies, and organizations delivering ongoing support in the home. Obvious story is who made the list, but the more important story is the purchasing rule that Medicare is testing. What does work outside of the clinic have to become before it can be reimbursable? Access does not broadly make social care a Medicare benefit. It creates an outcome aligned payment pathways for organizations managing specific chronic conditions in original Medicare. Those conditions include hypertension, diabetes, chronic kidney disease, obesity, chronic pain, depression, and anxiety. So participants can combine clinical consultations with nutrition, exercise, behavioral support, patient education, care coordination, medication management, and remote monitoring. But Medicare isn't paying simply because those services are valuable. It's tied to whether patients achieve defined outcomes such as lower blood pressure, improved A1C, weight reduction, or improvement in pain, mood, and function. So the accepted applicant list includes organizations such as Berry Street, Care Harmony, Castlight, Pair Team, Pocket RN, Food Smart, and Nourished RX, and a much larger group of clinical and technology enabled providers. They do different things, but inside of Access, their work must fit the same operating structure. That's a defined condition, clinical oversight, coordination with the patient's existing providers, and interoperable data exchange, measurable outcomes, and a payment that is at least partly contingent on performance. And that is what turns support delivered between appointments into something that Medicare can test as accountable healthcare. And that fits a larger shift that I've been tracking here at Pull over the last year. And that's for the past decade. Healthcare expanded the number of ways that social and non-traditional services could be funded. Medicare Advantage added supplemental benefits. Medicaid expanded health-related social needs authorities, and states invested billions in delivery infrastructure. But the market is moving from expansion to selection. CMS ended the Medicare Advantage VBID model after it was associated with $2.3 billion in excess costs in 2021 and another $2.2 billion in 2022. So now with Access, CMS is testing recurring payments with a full amount tied to measurable clinical results. That is not a retreat from whole person care. It's a higher standard for purchasing it. For healthcare executives, the lesson is not to copy the Access participant list. It's to recognize the purchasing architecture. Healthcare is increasingly willing to fund nutrition, navigation, behavioral support, home-based care, and remote monitoring when 5 things are present. Number 1, the work addresses a defined clinical or financial exposure. Number 2, it operates under clinical accountability. Number 3, it can be coordinated through existing care teams. And number 4, its results can be observed through trusted data, and the contract makes the provider accountable for performance. This category alone does not make something fundable, but its attachment to an accountable operating model does. That's what I'll be watching as Access continues to develop, not simply about which organizations participate, but which capabilities will produce measurable results, which ones will earn full payment, and which ones ultimately survive beyond demonstration. Because Access does not prove that Medicare will pay for everything outside of the clinic. It shows us what CMS believes is ready to be tested as a part of accountable chronic care. And for anyone building or buying social care, that is the signal today.